Okay, you're in the ICU. Your patient is crashing, and you need to get them on a ventilator right now. Those first 5 minutes, they are absolutely make or break, and there's just no time to second guess yourself. So let's get right into it. We're going to walk through the protocol step by step so you can move fast and with confidence.
So picture this. A patient is in acute respiratory failure. The clock is ticking. What are the very first, most critical things you need to do? Well, it all boils down to one fundamental question.
And that question is, does this patient really need a tube? Before you reach for a single piece of equipment, you have to confirm the indication. So, let's run through what we call the Big Five.
All right, so these are your classic can't-miss reasons. First, refractory hypoxemia. Their O2 sats just won't come up. Second, hypercapnia with acidosis. They're retaining CO2 and their blood pH is dropping. Third, apnea or impending arrest. That's a total no-brainer. Fourth, severe shock. And last, a GCS of 8 or less, which brings us to a really important point.
And that is this absolute golden rule. If the patient cannot protect their own airway, you intubate. Period. It's all about safety. It's non-negotiable.
Okay, so you've confirmed the indication, you're moving forward. Now what? Now we follow the ICU gold standard protocol. This is your roadmap to getting it right every single time.
It really breaks down into 5 straightforward steps. We've already nailed step 1, confirm the indication. Next up, you've got to choose your mode, and your default workhorse is almost always going to be assist control. Then, you dial in safe initial settings, get sedation and pain control on board, and finally, and you can never, ever skip this, you do your immediate safety checks the second they're connected.
So what do those starter settings look like? Well, you're going to start the FiO2 at 100%, crank it all the way up. But then you need to bring it down fast to avoid oxygen toxicity. Now for tidal volume, and this is so important, you're using their ideal body weight, not their actual weight. This is all about protecting the lungs. In fact, if you suspect ARDS, you're going to be even more careful and start down at 6 ml per kilogram.
The patient is connected. Do not walk away. This checklist is everything. You're going to visually confirm you see chest rise. You're going to listen for breath sounds on both sides. Confirm you've got end-tidal CO2. Then you'll order a stat chest x-ray and get an arterial blood gas within about 30 minutes. That ABG is going to tell you how you're doing. Just to give you a little context on modes, think of it like this. Assist control, or AC, is for your sickest patients. It does all the work. We use it for ARDS, sepsis, post-arrest, when the patient needs full support. On the other hand, modes like SIMV are partial support. That's what you'll use when the patient is getting stronger and you're starting to think about weaning them off the vent.
And really, if you remember nothing else, remember this, the ICU golden rule. The priorities are always in this order. First, fix the oxygenation. Second, fix the ventilation. That's getting rid of the CO2. Third, make sure the patient is comfortable. Only after you've stabilized those 3 things do you start to fine-tune. That first blood gas you get, that's your roadmap for what to adjust next.